Assalamu alaikum. Good afternoon, everyone. Glad to be here for the second consecutive year in Gulf Intervention Society. And in the coming 20 to 30 minutes, I'll be discussing with you one of the hot issues, both for direct patient care as well as in the literature. I'll be discussing short double antiplatelet therapy. And we'll be showing the evidence. What's the recent evidence? And if I ask any interventionist in the room, what would be your biggest concern once you deploy a stent in the coronary and the patient is out of table, then I would think of two issues. First issue is having acute stent thrombosis. And the second issue is having bleeding that would necessitate either transfusion or stopping the dual antiplatelets, which would also lead to thrombosis. So how do we balance these concerns of avoiding stent thrombosis and in the same time avoiding bleeding? And we're always caught between a short duration of dual antiplatelets versus a long duration of dual antiplatelets. We know from the old studies of early days of clopidogrel that we're not giving dual antiplatelets just for the sake of the stent. We give them because along the first year and the second year after an acute coronary syndrome, there is a significant chance of recurrent events outside the stented segment. These patients can have a repeat non-ST ACS, not due to stent thrombosis. So the longer the duration of dual antiplatelet therapy, the better chances we have to reduce these ischemic events. And lately we have studies on ticagrelor monotherapy after an extended more than 1 year beyond the acute coronary syndrome. So definitely, if we extend the duration of antiplatelet therapy, there is a benefit that we get. However, this benefit comes at a cost, which is an increase in the bleeding. So to reduce bleeding, you need a short duration of dual antiplatelet, whereas to reduce thrombotic events, you need a longer duration of dual antiplatelet therapy. So how can we balance these two things, bleeding versus thrombosis? First, we need to identify which patients are at high risk for bleeding. And recently, there has been a consensus document from the ARC, the Academic Research Consortium, about which patients are high risk for bleeding. And for the first time, they came with a set of criteria by which, when you have these criteria, you can identify your patient as high bleeding risk. They came up with major criteria and minor criteria. If you have one major criterion, then your patient is definitely high bleeding risk. If you have two minor criteria, then still your patient classifies as a high bleeding risk. It's needless to say that if you compile more than one of these major risk factors for bleeding, then the risk of bleeding will go higher and higher. To summarize them, the risk factors that we see in daily practice for bleeding include advanced age, renal failure, and with increasing severity, the risk of bleeding will increase, chronic liver disease, active cancer, anemia, unexplained hemoglobin drop, thrombocytopenia. The presence of an ischemic stroke is also a risk factor for bleeding, needless to say, a hemorrhagic stroke. Patients on polypharmacy, especially oral anticoagulants, for atrial fibrillation, which is now on the rise, or patients taking non-steroidal anti-inflammatory drugs over the counter. So, and patients who require a planned surgery or an unplanned surgery. So, all these factors are so prevalent in our practice that in the Burn PCI registry, 40% of our patients had one of these factors that increased the risk of bleeding. So if we go with the extended duration of dual antiplatelet therapy in these patients, we may reduce ischemic events, but the bleeding events will creep higher and higher. So in patients with high risk of ischemic events, for example, a patient with stent thrombosis, a patient with an acute myocardial infarction, patients with stented segments more than 60 millimeters, there will be a definite benefit from increasing the duration of that. Whereas in patients whom we just previously described, who qualify as high bleeding risk, shortening the duration of that would be ideal. So where is the sweet spot where you avoid ischemic events and at the same time you avoid bleeding events? And to complicate things further, some factors cannot be controlled for. For example, patients' non-adherence to treatment, unexpected interruptions because of an emergency surgery, or interruption by other healthcare professionals. These make things more complex. So what do the guidelines say? The guidelines classify patients whether they have high bleeding risk or no, whether they are acute coronary syndromes or stable coronary syndromes. And I would like you to look at the 2x2 table on the left side of the right side of the screen. Patients with stable coronary artery disease, they have a lower risk of ischemic events. Therefore, the duration of dual antiplatelet therapy can definitely be shortened. Whereas patients with acute coronary syndrome, they have a high ischemic risk. Therefore, the duration of antiplatelet therapy should better be prolonged. And the other factor, if the patient is a high bleeding risk, then you go towards the short duration. If he's not high bleeding risk, then you try to go for the long duration. So the trade-off based on the guidelines for patients with high bleeding risk would be 1 to 3 months, but still in patients with acute coronary syndromes, it's 6 months. So for ACS, you'll probably be stuck for 6 months. Is there a way to escape from that? By changing the stent platform. And of course, there's been trials for the last decade on this issue. But before going to the trials, we need to think, which is the antiplatelet that is indispensable and which antiplatelet we can easily omit. We have now 4 different antiplatelets, of course the old aspirin, cyclooxygenase inhibitor, and the thienopyridine antagonists, clopidogrel, ticagrelor, and prasugrel. Prasugrel is not available in the region, so we'll not be discussing that. From the clopidogrel, ticagrelor, aspirin, we know that the antithrombotic efficacy of aspirin is the lowest among the 3. And the highest potency is for ticagrelor and clopidogrel. That's why there is a recent trend towards de-escalation of antiplatelet therapy from the potent ticagrelor into the less potent clopidogrel after you pass the window of subacute stent thrombosis. So if there is one agent that you are likely to omit, it's aspirin, because its antithrombotic efficacy is not as strong. That's number 1. Number 2, it has a direct effect on the GI toxicity, which is independent of its antiplatelet effect. So if you omit one, it will definitely be aspirin. You continue on either clopidogrel or ticagrelor. So what evidence do we have in the last decade on short depth? We have several trials with different stent platforms, and we'll go through them quickly. We'll start by the oldest one, which is the leader's trial, which compared the biofreedom stent versus the Gazelle bare metal stent. And in this study, that was mandated for only 1 month, followed by long-term single antiplatelet therapy. And they had a primary safety endpoint, which is death MI, which is ischemic events, and an efficacy endpoint, which is target lesion revascularization. So what did the study show? The study showed that the biofreedom could reduce the safety endpoint of death MI or deafened stent thrombosis compared to the bare metal stent. So probably we don't need bare metal stents anymore if you're concerned about the need for dual antiplatelet therapy. But looking at the trial and looking deeply into the numbers, we realize that the risks that we're seeing in both arms were significantly high. Looking death at 2 years, 6.6% and 6.9%, this is way high. And it's probably unacceptable in the current era where everyone is looking for safety and events count against the physician. Stent thrombosis rates were relatively high, 2.2%, which means out of every 50 patients you insert a stent, 1 of them will get stent thrombosis. So if you're a high volume center and you do 1,000 stents a year, then think how much stent thrombosis would you get. So there was a definite need to change the platforms towards a better platform which will give you lower rates of events. Recently came the Onyx 1 trial, which was a direct head-to-head comparison between Resolute Onyx, one of the best stents, versus the biofreedom. And both patients cohort got 1 month of dual antiplatelet therapy and the same safety endpoints and secondary efficacy endpoints. And as you can see, death, MI, or stent thrombosis were not different at the 1 month between the two stents. But still, the event rate is extremely high. It's 17% at 12 months, which means that closely one out of every 5 patients would have one of these events, death, MI, or stent thrombosis. So still the numbers are exceedingly high and probably unacceptable in our current practice. And recently came the Stop DAPT study, which enrolled initially 6,000 patients, and it randomized them into 1 month DAPT versus 12 month DAPT with a platform which is basically a Zions Alpine stent. So the question here, if you place a Zions stent, would it be sufficient to give only 1 month of dual antiplatelet therapy, or you still need to give the 12-month dual antiplatelet therapy? And we got 1,500 patients in each arm, and they were followed up for 1 year. And what did the study show? That the ischemic events were comparable. But if you take a composite endpoint of ischemia and bleeding, then definitely the 1 month regimen was superior. So it's probably only required for 1 month. A point to consider that 30% of patients in this study had an acute coronary syndrome, and 70% had stable coronary artery disease. So this study is probably representative of the daily clinical practice. And if you compare these numbers, the absolute figures, to the absolute figures that we were just showing, that you can see the death, MI, stroke is exceedingly low. This is what you expect from a modern platform in the current perspective, in the current era. You're talking about ischemic endpoints, death, MI, stroke of only 2%. And if you take, and there was a sub-study of the whole population of the short DAPT, looking particularly at patients with high bleeding risk. The patients that we just enlisted, those of advanced age, renal failure, history of bleeding, history of stroke, 1 major criteria or 2 minor criteria. And among the selected patients, they could randomize 500 patients to the 1 month arm, and 496 patients to the 1 month DAPT arm, and 951 patients to the 12 month DAPT arm. And as you can expect, the numbers were significantly better when you gave only 1 month dual antiplatelet therapy in the high bleeding risk patients. And high bleeding risk is not only high bleeding, it's a high risk for ischemic events. So if you look here at the 4 subgroups, patients with high bleeding risk and the 12-month therapy, they had 6% chance of events, compared to 2.4 only if they were given 1 month DAPT with Zions Alpine. Patients with no high bleeding risk, of course, they did better, also better with a 1 month DAPT therapy. And this was mainly driven by a reduction in the bleeding events. Whether you take TIMI bleeding or BARC 3 or 5 bleeding, the bleeding was significantly less with a 1 month protocol compared to the 12-month protocol, without a statistically significant increase in the ischemic events. So why is this specific platform, Zions Alpine, did it show better safety regards ischemia and bleeding? It's probably because of the fluorinated polymer. It seems in benchmark tests and benchmark experiments that the tendency of this fluorinated polymer to attract platelets is the lowest in the Zions platform. And there was this test where they exposed the stent to a flow of platelets, and they compared the Zions to the Resolute Onyx. Zions had much lower platelet aggregation. Comparing to the Orsiro, it still had a lower platelet aggregation. Comparing it to the Synergy, it still had lower platelet aggregation. So it's probably the fluorinated carbon polymer is behind this more thrombus-resistant platform. So to conclude, if you want to find the sweet spot to avoid bleeding and at the same time not increasing the ischemic events in patients with high bleeding risk, when you're forced to stop the dual antiplatelet therapy, then probably the platform of Xience Alpine seems to give the best results. Thank you so much.